everybody, and welcome to our third session, our third webinar series. So, finding new ways to improve healthcare for everyone in West Yorkshire. And today we are concentrating on who is in West Yorkshire and how we can all work together. So, what I thought we'd use today's session just initially, we're halfway now, so we've got today and next week, and that will sadly be our last one for now. We were just sort of reminiscing how quickly it's gone, so I thought it'd be a good place to just really reflect where we've been and what we've covered and what's left to come over today and next week as well. We've had really great feedback, so thank you so much to everybody who has taken the time to give us their feedback. It really is appreciated, and we look through every single one and really try to improve the session based on your suggestions. So we've had a few, and I think it'd be obviously for those who were with us on the first series, we had to cover a lot in that one because it was very much sort of contextual and sort of framing, how the webinar series came about. So we didn't have much time to fit much more in. So today I just thought it'd be good just to go over some of the things that we've covered, just to capture some of that learning. So in sort of a nutshell, the webinar series aims to kickstart that culture of innovation within West Yorkshire. So the project that we're running for these webinar series is part of a wide strategic aim, and that's working with the West Yorkshire Innovation Hub to explore one of the West Yorkshire Integrated Care Board's, the ICB's, innovation commitment in depth. So these sessions are very much about the emphasis on innovation and reducing health inequalities. So it's about how we can ensure that new advancements don't widen those existing health inequalities gap. And to help us in delivering that aim, the series is very much coined around that learn, connect and empower. So the idea that you come to these sessions to learn, not just through sort of the information that we give you, but through the stories that we hear about from our amazing speakers that we've had, and then use that, to connect with one another and with the speakers as well. Hopefully that will then provide you with the confidence to sort of empower yourselves to take forward into your individual places of work something that you want to move forward, and we can 100% fully support you sort of within that. So just to cast your mind back to webinar 1, and that was understanding the essentials, and as I've already sort of alluded to, that was really about understanding everything. I've sort of banged on about this on every single series, but the idea is not for you guys to become experts in any of the subjects that we're talking about. It's really to let you know of we wanted to use the webinars as a platform to showcase some of the amazing work that is happening in our area, so that you're aware of what's happening and you have an understanding of that activity, to then make those connections and go into your individual places of work to potentially do something similar. So the first one was about, if you remember, James introduced the session to the health system and how that fits in with West Yorkshire. We did sort of an understanding of what innovation is and how it differs to transformation and improvement. We also did a session about research and the role that plays within healthcare innovation and health inequalities. And obviously, lastly, we really brings up what brought all the webinar series together, is the health inequalities aspect. It's an incredibly complex subject, and rightly so. And what we really want these webinars to achieve is to support you guys in knowing what you could do within your individual roles. And the take-home message is that it's the responsibility of everybody within this call to really go back and do something to try and tackle health inequalities. And it is something that we are all able to do. Webinar 2 was about the importance of fair opportunities in healthcare. So we invited 100% digital leads to come and talk about inclusive innovation and digital innovative solutions. We also did a piece on the patient and public involvement and engagement. Again, an absolutely vital piece of work. We had Graham talk about, and I know some of you have already contacted Graham, which is absolutely amazing. Because if we are sort of designing ways forward, we really do need to ensure that we bring everybody along with that right from the very start, and particularly the communities who are often forgotten. So I cannot stress that point enough, really. We did a bit about sort of unconscious bias and the role that plays in healthcare inequalities, and we looked at some of the practical tools for you to use to avoid that to avoid that confirmation bias as well. So looking at today then, we've got an amazing lineup of speakers who are going to talk to you today about, like I've already said, who's in West Yorkshire and how we can work together. So this is very much about the collaborative piece. So we want you to be able to gain an insight into West Yorkshire's population diversity. And that's really important. So for anybody on the call with us today who isn't from West Yorkshire, I know there are a few of you, the sort of transferable take-home messages here is it's really important for you to understand the population in which you work, because if you truly understand that population, then you can help with some of the barriers that they face in terms of accessing healthcare. So it's really important to know who you're working with. It's also to learn about sort of the collaborative systems across West Yorkshire, understanding how data utilisation can be used to reduce health inequality. So we have an amazing story today about how just doing something slightly different or looking at something in a different way actually has sort of a profound impact, especially on those communities that we're trying to help the most. So that really brings us neatly on to our last session, which is to expect next week. And this is about making it happen. So this is about giving you guys the opportunity to, introduce yourselves to one another and get that organic, natural conversation flowing about, where you work, what you've been up to, what your role is, and very briefly, so nothing onerous. And it's just really to allow you to make connections and swap information if you want to. If you haven't been involved in this type of work before, absolutely brilliant. Hopefully you've learnt loads within this. Also, just as a heads up on the last one, we will be asking you for your call to action. That's essentially trying to look at what you've learnt over the past 4 weeks, and what it is, or what you want to do to take forward in your individual places of work to make impactful change. And just really keen to stress that these do not have to be big massive gestures. It's often the smallest actions that we can all do collectively that make the biggest impact. So just have a think about that for next session, but we will touch on that more obviously next week, so don't worry about it too much, but we will hopefully be moving that forward as well for you. So then, without further ado, I'll be introducing you to the speakers that we have today. So we have who's the Head of Improving Population Health, West Yorkshire ICB. And we'll be talking about some of that collaborative working that I was just talking about there. We have also Verity and Ruth from the Yorkshire Ambulance Service, who will be coming to talk to you about the amazing work that they've been doing within their area, utilising some of the data that they have there. So, Em, the floor is yours.
So first, I think, oh, there's an echo. There we go. First thing of the day is trying to unmute, but there we go. So thanks, Kim, and thanks for inviting me to speak today. I'm just going to go through a few slides around the population of West Yorkshire, but then go on to talking about why we need to tackle inequalities and why we need to tackle them together. So hopefully that'll give you some information that will be helpful. So I'm going to look at why it's absolutely necessary for us to work collectively across the entire system to address health inequalities. They're a persistent issue and they impact all of our communities. And obviously this is something that's across the whole of the UK, but West Yorkshire is particularly affected by inequalities. They're driven by social, economic and environmental factors, and they result in poor health outcomes, uneven and unequal access to services and support. And that can differ as well between our different places that we've got across West Yorkshire. So hopefully by the end of the presentation, I'll have explained why it's really important for us to address these inequalities together to ensure a healthier future for everyone who lives and works across West Yorkshire. Next slide, please. So the first step in addressing inequalities is about understanding the demographics of our population. So we need to understand the communities, how they're made up, in order for us to be able to really target, design, co-produce, more importantly, services that will best meet their needs. So it's about having that clear insight into who makes up our population, where they live, the types of context of their lives that they live in, and the challenges that they face. And that ensures, or helps us at least, ensure that our strategies are as targeted as possible to meet needs. It's not a one size fits all, and it requires a lot of intelligence and data to really understand the population to ensure that our services are equitable, inclusive and effective. Next slide, please. So we know that West Yorkshire has got a tremendous amount of diversity. And we've got a population of 2.3 million people. And then amongst that population, we've got 15.9% of our population who identify as Asian or Asian British. And 1 in 6 people identifying as Pakistani. And across England, this is, you know, significant in West Yorkshire compared to across England. But this diversity often intersects with other significant disadvantages. And that's a really crucial point, because while diversity brings many strengths and absolutely brings difference to our communities that we can build on, and that shared learning of lives that are different either culturally or ethnically, it also means that we've got many challenges, especially in terms of health, and that these are complex challenges and interconnected and directly impact on how people access healthcare services, both from whether or not our services are accessible to them, because this isn't about, I hate the term, hard to reach populations. They're not hard to reach. Our services are hard to reach and our doors are closed. But also the mistrust that we've got from some populations in statutory services. But it doesn't just impact on health, it impacts on other opportunities like education, working, and overall quality of life. Next slide, please. So the disparity that we see across West Yorkshire within our population is reflected in morbidity and mortality rates, reductions in life expectancy, and the number of healthy years lived. And these are more than just numbers. There's stories behind all these numbers, what's happened to people and their lives. And actually they represent lives that are cut short, potential that's unrealised. And I've worked across West Yorkshire in all settings, and in particular in prison, and asked a group of men in prison once, what do they aspire to be? And 90% of them said they'd never been asked that question before. So actually, you know, this isn't just about people suffering from poor health. This is about people not having relationships, trusted relationships, feeling that they live in safe, psychologically and physical environments. And communities are suffering in silence, and don't often get heard. So behind every number, behind all the data, is a person, is a family, and is a community. And they're not experiencing the same levels of opportunity and support that the majority of the population receive. So it's our responsibility collectively to change that. Next slide, please. So there's some data on this slide. Verity and Ruth know me very well, and they know that I do not like data. So I am not going to claim that this was my work. This was not. This was our fabulous data analyst. And this data highlights the intersectionality between ethnicity and deprivation across West Yorkshire. And it really emphasises the significant social and economic inequalities within our population. And you can see on this slide that 523,000 people live in the IMD1, which is the most deprived decile. What we do know is 45% of the inequalities across West Yorkshire are in Bradford. So not only do we have vast inequalities across West Yorkshire, but they are also unequal in where they're positioned across the region. So it's a huge number showing the scale of deprivation across the region, but probably more strikingly is that 42% of people who identify as being in an ethnic minority reside in the most deprived areas. So the chart continues to break down the population by ethnic group. It looks at the 10 deciles of deprivation from the most deprived to the least. And again, 232,000 people from an ethnic minority living in the most deprived areas. So as we move across, you can see that there's a clear pattern between ethnic minority and disproportionality, and that is definitely represented in our areas with the most deprivation. And it provides a really powerful visual representation of the structural inequalities that we have across our system for ethnic groups. And it reinforces why we've got to have the targeted interventions to address not just the inequalities and the deprivation inequalities and socioeconomic inequalities, but our ethnic inequalities as well. Next slide, please. So as well as ethnicity, inclusion health is a massive priority across West Yorkshire. And this is really looking at the health disparities between our population groups who are the most marginalised in society, are most vulnerable. So people who are of sleeping, people with mental ill health, people who are in the criminal justice system or using alcohol and drugs, and sex workers, etc. And I do apologise if my language is different to the language that other people use. We do try and be very trauma informed in our language, but we can't always use the right terminology for everyone. So what we want to do through our health inequalities work is look at those populations who are most vulnerable, but ensure that the workforce that's working and supporting them has the development and has the knowledge and skills that they need. Ensuring that we've got that integrated service delivery, because if we don't have that, we can't address the multiple needs that these adults and children are facing in order to improve outcomes. So what we know across West Yorkshire is that we've got 2,759 people recorded as statutory homeless. And this doesn't just impact on their physical health, it impacts on their emotional health and well-being, their ability to have a bank account and financial security, their ability to have employment and an address. So it culminates in a collective of trauma and adversity that then exacerbates the poor health and outcomes that people are experiencing. The average age of death for a rough sleeper is 44 years old. In today's times, that's incredibly alarming. And it's a huge indicator of the severe health risks that are faced by these vulnerable groups. We have 2,311 gypsies and Irish travellers living on sites across our region, and they have a life expectancy of around 50 years. So again, these are big parts of our population and our communities who are underserved, facing severe inequalities and dying too soon. So the figures on this slide, also illustrate the critical health inequalities affecting these communities, particularly as well our asylum seekers and refugees. We've got around 1,500 living in contingency accommodation across West Yorkshire, and that accommodation is becoming even more challenging and difficult for the people in there when we're doubling up on rooms in hotels. So these groups are often not just excluded from services, but excluded from society and all the protective factors that would support them to respond to the inequalities and the poor outcomes that they're facing. So we need to have a trauma-informed approach to ensure that these populations and these groups are not left behind. Next slide, please. And please do keep me to time, Kim, because I can talk a lot. So life expectancy. This is something that in my programme in Improving Population Health, we've had as a big ambition across West Yorkshire for the last 6, maybe even 8 years now. Time's ticking by. And it's not just about life expectancy, it's also about healthy years lived. So life expectancy is another indicator of inequalities across West Yorkshire. And what this slide shows is how life expectancy is also related to deprivation. So it breaks it down by different conditions and different genders. And you can see that if you look at gender, the gap in life expectancy between the most and least deprived across West Yorkshire is 8.9 for men and 8 for women. And again, that's just in West Yorkshire. What we also know is that people in the north of England, the life expectancy is 10 years less than people in the south. And those figures show us that we've got to do something. We can't just keep doing what we've been doing because they won't improve. For the men in our society, it's conditions such as heart disease, stroke, lung cancer that have had the most significant impact, and particularly in those deprived communities. And for women across our population, heart disease, stroke, and respiratory diseases. And they're all contributing to that reduction, not just in life expectancy, but healthy years lived. So this shows us why we really need to target public health interventions and health services to reduce inequalities across West Yorkshire. And we need to do that by addressing the root causes of deprivation and the root causes of trauma and adversity, of serious violence, and all the different things that contribute to inequalities. We know that none of these conditions, these long-term conditions, are distributed evenly across our population. And so we need to look at how we react to that and respond to that and understand the differing needs of those groups so that we can ensure that services are getting to those that are most deprived, but not asking people to come out to our services, but by taking services to them and being more innovative in the way that we do that, because these are the groups that are bearing the brunt of the poor health outcomes across West Yorkshire. Next slide, please, Kim. So as I've alluded to, in order to understand and respond to inequalities, we have to look at the relationship between socioeconomic status, ethnicity, geography, and health outcomes, because it's undeniable the intersectionality that exists across all these different dimensions. And they not only contribute, but exacerbate poor health and life outcomes. So the message really is clear. We can't continue to do what we've always done. We can't continue with a one-size-fits-all approach. To address these statistics, these numbers, and the stories and the families and the people that are behind them, we need to really understand these inequalities. We need to target and tailor our interventions and recognise the unique challenges and needs that are faced by our different population groups. And so in improving population health, we look at this through a life course approach, which you can see on this slide. And what we look at is throughout that life course, where are the key times that these different conditions or the root causes, determinants of health impact on people and their lives. And so you'll see that different inequalities manifest at different times. In childhood, we're doing a lot of work around asthma and respiratory disease and young people's mental health. And then, of course, in our older population, we're looking at frailty. But one of the things that goes across this entire pathway is trauma and adversity, and how we respond to that to prevent trauma from happening in the first place, but to intervene early and mitigate harm where it has happened along that life course, because that can really change the future and the healthy years lived and increase life expectancy for our population. Next slide, please, Kim. But we also know within our programme, within the integrated care system, that only 20% of what ails us is dealt with in a health and care setting, and that the remaining 80% of what we go through and what impacts our lives and our opportunities and whether or not we thrive comes from those wider determinants of health, where we live, whether we have access to education. Education is so crucial, and young people not being excluded from school. And our stats tell us across West Yorkshire that the vast inequalities in ethnicity on the numbers of young people who are excluded from school and permanently excluded. And that leads on a pipeline often from education to prison and youth justice. Employment and worklessness, not only something that is affected by where people live, but affected by poor health and being able to work. So it's cumulative, and none of these things are happening in silo. So there has to be a point where our approach to tackling inequalities needs to reach much further beyond the walls of a hospital, beyond health and care settings. And the integrated care system very much recognises that. And it's really difficult in the current climate for us to be able to put that into practice, but we need to always keep it at the forefront of our minds. We've got to involve policies that address poverty. We've got to look at promoting equitable access to education and employment. That's just as important to health and care as it is to all other sectors. And we've got to create the environments that enable our population to live healthy, fulfilling lives and have those protective factors to help them improve the situations that they're living in, navigate the systems that are unequal, and be able to access the support that they need. Next slide, please, Kim. So responding to health inequalities has to be collective. It's not enough for one organisation to take this on. It's not just health inequalities need to be addressed by health and social inequalities need to be addressed by local authorities. They're all inequalities that are all interdependent of each other. And in order to be able to address them, because they are systemic, we need solutions that are also systemic. So we need to integrate our services and support, and we need to work together across every sector: health, social care, education, police, employment, to ensure, again, that no one's left behind. Next slide, please, Kim. So this is the Improving Population Health programme. You can see it's got a vast amount of work streams and areas of focus within it, all of which are interdependent and work together in order to address inequalities across our system. And it requires us to deliver this programme for us to look beyond the health and care system. So the majority of the work that we do are with partners outside of health. And they're with partners. I have a joint post. I'm public health lead for the Violence Reduction Partnership, for example. We work very closely with the West Yorkshire Combined Authority, and we have a shared public health consultant role that goes across there. Ruth and I have done lots of work together in the past with blue light services and various others. So we're constantly working with partners from across the system in order to help our population have the environment that will help them thrive. And so we need to look at how we support people to face the challenges that they see every day, that they face every day in daily life. And we want to do that by understanding the role that we contribute in the determinants of health and how we can deliver our priorities to support not just health and care services, but the whole system. So we build connections regularly. I often say that my role is a big dating agency, because what we do is we bring people together, we connect the system to itself. And we work in partnership all the time to address the issues and the big issues that affect, health and care, waiting lists, waiting well, secondary prevention around long-term conditions, personalisation. We can't do those things on our own. We have to work with the rest of the system. And that will not just reduce the burden on health and care, but it will ensure that we start to intervene early and prevent what we know is predictable from happening. And that will help us have a more sustainable impact in our communities. An example of the work that we've done across West Yorkshire, there's a few actually that I could mention. The suicide prevention programme, how we work with our partners across local authorities in order to reduce suicide rates across West Yorkshire. The Adversity Trauma and Resilience programme, which has got over 700 colleagues working on it from across the system. In fact, we've got a criminal justice conference that we're hosting tomorrow, because we know how important it is to prevent trauma and re-traumatisation, not just for our population, but for our workforce. The Health Inequalities Academy, where we've got a health inequalities, improving population health fellowship, where we're increasing capability and capacity and intelligence in the system. But we don't always get it right. And some good examples of that were around our primary prevention work, physical activity and obesity, for example. Their whole system approach is where the majority of that work needs to be done in the wider system. And actually, when we were trying to pull that together, we wanted to be everything to everybody, and we couldn't. And then we caused quite a lot of confusion in the system, and we had to take a few step backs and think, right, what is the role of health and care to bring to the table to a whole system approach? So it's not always easy, but actually what we know is that being part of something bigger than us is going to make the change that we need. Next slide, please, Kim. We also know the importance of technology to address inequalities, and with the caveat that we don't want to broaden the inequalities gap through digital exclusion either. But we know that if we work with partners across digital solutions, that we can look at how services can be even more closer to home, be more accessible for our families and communities. But we can also share resource, share technology, share data, which is something we've been trying to do for a very long time across the whole of the country and West Yorkshire. And that then allows us to coordinate efforts in a way that ensures that digital inclusion is there. So local authorities can help us access and know more and learn about our communities where digital exclusion might be an issue, and support us on how we can start to build health tech into those communities without it being a challenge or contributing to that mistrust and inaccessibility. And we also know that by embracing tech and embracing new technologies, it also empowers the workforce and we can provide that joint training using digital tools to support both the capacity and capability of the workforce, but also that personalised care and improve outcomes for our population. Next slide, please, Kim. So supporting the workforce is incredibly important if we want to reduce inequalities. It's not one workforce, it's not one organisation. We have to work together as a system. And we often talk about the I in inequalities. It's everybody's business. But what we don't want it to be is everybody saying it's everybody's business, but actually nobody's doing it. So it's about really understanding what our contribution is. So what is my I in inequalities, and what can I do in my role as head of improving population health? And what we do know through our programme is that we can create a healthier and fairer society by increasing capability, capacity and knowledge across the system around things like trauma-informed approaches, cultural competency. And we can make a significant impact and reach far out into those communities and those diverse populations that needs those services and support the most, ensuring that we're delivering an equitable and inclusive way. But we can't do that on our own. And we need the workforce to feel supported. We need to care for the carers in order to be able to tackle health inequalities head on. Last slide, please, Kim. So just to summarise what I've said, hopefully it's made some sense. I do find that I'm getting older and my words don't come out quite as well as I expect them to. So hopefully that was intelligible for everybody. In summary, we've got to have collective action if we want to build a healthier and more equitable future. We've got to understand the makeup of our population, their differing needs based on ethnicity, culture, age, gender, and also really understand those vulnerable populations and what they're going through, and understand their stories, what they've been through, and how's their story contributed to the inequalities that they're facing. If we don't do anything, the inequalities will become too vast and the connectedness that we have across our system will break down. So we need to keep that in mind, and we need to stay connected with each other. The solutions to this lie in our ability to work together across sectors, disciplines and communities, pooling resources, knowledge and efforts where we can to create lasting change. And if we do this, we can make a profound difference. Collaboration is at the heart of our approach. And that means that stakeholders from all parts of the system are involved, each having a unique role that they can play in shaping the environment that people live in, regardless of people's circumstances and what's happened to them. And we can give them that opportunity to thrive, where they are asked a simple question like, what do you aspire to be when you're older? So together we can build a future where every individual in West Yorkshire has the opportunity to live a long, healthy and fulfilling life. And that's it from me, Kim.
Absolutely amazing, Em. Thank you so much. And I thought you were incredibly eloquent and captured everything absolutely brilliantly. So thank you so much. We have Ruth and Verity who are going to sort of bring everything that Emma's just said and show you how that would, how that works in practice actually when you recognise that you can work collectively together, sort of the great thing that you can achieve. I just wanted to sort of touch on, I sort of appreciate how big this might feel if you're sat behind a computer or in your role clinically and you're thinking, but where would I start? The first thing really is just being aware that there are others out there who are exactly like you, who are wanting to take things forward. So the first thing that you could do is just ask that question. And believe me, one question it leads on to another, leads on to another, leads on to another. And it can sometimes feel like it's a can of worms sort of that you've opened, but it's the best can of worms that you will ever open. So the biggest bit of advice that I can offer is just ask the question and don't be ignorant. Don't make assumptions, just speak to people, and that will open more doors for you. So that's where you start, just ask questions. And on that lovely note, we're going to pass over to Verity and Ruth so that you guys can share the amazing work that you guys have been up to recently as well. The floor is yours.
Thank you. So I think I'm going to kick off with a bit of background, and then I'll pass you on to Verity to kind of go over what we've done in practice. So if you could just possibly move on to the next slide, that'd be lovely. Okay, so like when we're talking about health inequalities, I like to bring it back to real people. Unlike my words have never come out as I have expected them to, so this presentation may have a different feel, but yeah, no, I'm really keen that we bring it back to real people and what it means in practice. So I've just popped a few statistics up there that always make me kind of stop and think whenever I see them. So for example, people experiencing homelessness are 14 times more likely to die by suicide than those in the general population. So absolutely, this is something that we can't ignore and shouldn't ignore. And the World Health Organization has neatly described what this means in real terms, using London tube stops. So when travelling east from Westminster, each tube stop represents nearly 1 year of life expectancy lost. And you can do the same sort of analysis in local areas as well. And I'm sure there's one been done in somewhere in West Yorkshire as well. It might be Bradford. But yeah, so that was just a bit of scene setting. So next slide, please. I also really like this quote from Dr. Paul Farmer. And I suppose thinking about health inequalities, and during COVID, when there was so much focus on health inequalities, it got me thinking, well, what's the role of the ambulance service? What's my role in all this, and what's the role of the broader sector? And I also have a role as the national lead for public health for the Association of Ambulance Chief Executives. So I had an opportunity to start to shape what it is, what we think our approach to this can be as a sector and as an organisation. Next slide, please. And actually, we've been thinking about this for quite a while. So back in 2017, ACE launched a consensus statement with Public Health England and NHS England and other stakeholders, which really kind of sought to set out the commitment of the ambulance sector to think more proactively in terms of kind of the health and well-being of our populations. But the more work we did around that, the more we realised that actually a public health approach wasn't necessarily particularly well understood within the ambulance sector. So in 2021, so obviously mid-COVID, we launched the discussion paper that's in the middle of the screen there, which really kind of sought to take the different elements of a public health approach and apply those and put those in the context of the ambulance sector. But whilst we were doing that, obviously, as I say, height of COVID, lots and lots of focus on health inequalities, and we started to say, okay, but what does that public health approach look like in the context of reducing health inequalities for the ambulance sector? So in 2022, we brought all of the partners of that original consensus statement back around the table to start that conversation around what can we do as a sector, and what can our individual trusts do in terms of that reducing health inequalities agenda. And the main output of that roundtable was that we would revisit that initial consensus statement to reflect this kind of shift in focus towards yes, taking a public health approach, but not so much kind of necessarily what it is that our frontline staff can do. And whilst that's still really, really important, there's also some of those more kind of upstream approaches that we can take that Em was mentioning earlier in terms of the kind of the determinants of health. Next slide, please. So last year we launched a suite of documents as part of that consensus statement. So we did a review of what we know, and these are all available on the ACE website for anybody who's interested. So we did a review of what we already know is happening within the sector. We published the consensus statement itself, which really kind of tried to set out what we think our specific role could be. And then there's also an implementation toolkit, which helps ambulance services with, I guess, the kind of practical implementation of the consensus. I think the consensus statement's great at kind of bringing all of those key national stakeholders together, but actually there's something about, okay, well, what do we do? What do we do in practice? And Verity will be talking a little bit about that as well in a moment. Next slide, please. One of the things that the consensus statement did was link kind of the 4 ICS core purposes with some key enablers that we identified at trust level that really need to be in place. I guess they're kind of building blocks towards embedding that kind of public health, reducing health inequalities approach across all of our services. And one of the things that we've talked about a lot as a sector is that we have lots of data, but we don't necessarily look at that from a public health perspective. And that's because we don't necessarily have those skill sets within our organisations. We have very skilled business intelligence teams, but they tend to look at our data from a kind of performance and demand perspective, whereas actually if we could bring that public health skill set into our organisations, we hypothesised that there was much more that our data could tell us, and that is essentially what Verity is going to be talking about now. So we've had Verity in the organisation for on and off kind of a year or so probably, and she's done wonders with our data. So I will hand you over to her now, and she can take you through what she's been doing.
Hi, so I'm Verity, and I'm a public health analyst, and I have been for a long time, longer than I care to mention. And I've worked in all sorts of bits of the system. Unlike I really like a bit of data. And I think if you've got the right data, you can really make a difference. And if you've got any data analysts on the call, which take note, there's all sorts of things we can do. The right data in the right place at the right time can make huge differences. So when we think about how do we look at our population, so as Em said, it's really important for us to understand our population. What's their need? What's wrong with them? What are the problems that are wrong with our population? In a system, we quite often look at primary care data because we have good access to primary care data. We look at A&E data when you go into hospital, what was wrong with you, and we look at inpatient data. So we're really good at looking at those data sets. What we don't look at, if you just click him, is we're not very good at looking at ambulance data. And another little click. Thank you. So that feels like a massive gap to me, and that's one of the reasons that I really wanted to do this job. I wanted to go and work with ambulance data because I've got a bee in my bonnet about how important I think that bit is. That is a really missing link. So the ambulance service comes into contact with some of the most vulnerable people in society. So some of those groups that Em's talked about, the ambulance service sometimes sees those people because they see them when they've got that emergency need. So if we're not looking at that ambulance data, we're missing some of the health need for some of those populations. Just click on again. Sorry, I really like animations, and it doesn't work as well if somebody else is driving. So in 2023, Yorkshire Ambulance Service dealt with almost 800,000 patients. Click again. And over a third of those aren't conveyed to hospital. So that's 288,000 people that we didn't take to hospital. So we don't know about them unless we look at, so if we tried to measure them like we normally would when we look at A&E data or inpatient data, we wouldn't know about them because the ambulance service haven't conveyed them to hospital. That doesn't mean they didn't have an important health need. So trying to understand what that health need of that population is really important. So next slide, please. So mental health is a really good example. So when we try and measure mental health, it's the need for mental health services in our population, we quite often use primary care data. So that tends to be how we find out about how many people we think have mental health disorders. Now that relies on you having gone to your GP when you're feeling very unwell, mentally unwell, actually having it together to want to go and speak to your GP and them having recorded it correctly on a system. So, but because we don't have any other good data on it, that's what we use to measure what is the prevalence of mental health problems in our population. So when we look at, so QOF is the Quality and Outcomes Framework, and that has GP related data on it. And we can estimate we have 54,000 people with common mental health disorders. However, when we look at ambulance data, we had 50,000 calls over the same period that were flagged as mental health. Now that's been poorly enough to have had to ring an ambulance to ring 999 because your mental health is so poor. Now that says to me that when by just measuring it via what has the GP's recorded is suspected a massive underestimate of the actual problem. Click again. So we only convey about 38% of mental health calls, and that's very good reasons, because sometimes, well, a lot of times, going to A&E probably isn't the right thing to happen to you if you've got a mental health crisis. But that means there were 31,000 calls in 2023 that were only seen by us. Now, we might be doing the right thing for those patients, but the ambulance service isn't necessarily set up to look after people with mental health calls. So it's about us getting them to the right place, but it's also got to be about us sharing some of this data with the people whose job it is to put in mental health services, because otherwise they don't know about these populations. And that's a big part of what Ruth and I have been trying to do. So if you just click on the monitor. So mental health is just an example. If you think about any conditions where you're unlikely to actually get admitted to hospital, it feels really important to then look at ambulance data. So I think things like alcohol and drugs, where the ambulance service might go out and see you, but they might not take you to hospital. Violence, suicide attempts, self-harm. There's a whole bunch of things there that the ambulance service probably know about. And if we don't look at that ambulance data, which we don't as a system at the moment, then we're going to be missing what's wrong with those people. We're going to be missing the story about those people. Next slide, please. So this is just some of the story that we found by looking at the ambulance data from this public health point of view, and also looking at from an inequalities point of view, because that was particularly what Ruth was interested in me having a look at. So overall, the rate of ambulance calls per thousand population is almost twice that in the most deprived area that it is in the least deprived. So we see much more demand from that most deprived population for the ambulance service. And what we wanted to do is try and understand, are the particular conditions, are the particular people from that most deprived group, what is the need that we're seeing in those most deprived? We know there's more need, but what is that and why is it different? Next slide, please. So if we look at breathing difficulties, so one of the biggest things that the ambulance service, the reasons that we go out to people is about breathing difficulties. We can see that's 2.5 times more likely in the most deprived group than it is in the most affluent. Now we know about some of that story. Some of that story is about smoking rates in the most deprived group are much higher. We know that people have industrial jobs, people have poorer air quality. There's a whole story there about why we might see more breathing difficulties in that most deprived group. We know that some of those industrial jobs and smoking rates will have led to poorer health conditions such as COPD and lung cancer, and those things will show that pattern. But we also saw the same pattern when we looked at young people at under 18s. So why is that? Why are we seeing that same problem for those under 18s? Well, we know it's not necessarily about that, but is it about damp housing, poor air quality? Can we understand that a bit more in a bit more detail? And next slide, please. When we look at mental health, the picture is even more so. So the difference between the most and least deprived was 5-fold. So people in the most deprived group were 5 times more likely than people in the least deprived. So they need to call an ambulance for their mental health. And I think that's a really shocking statistic. So we look at all those people who we already didn't know about, and we're just seeing so much more need in that most deprived group. Next slide, please. We also looked at 111 calls. So I'm sure you're all familiar with the 111 service. If you're not quite sure what to do, whether to go to your GP or whether you need to go into hospital, you might ring 111. And Yorkshire Ambulance Service also run the 111 service in Yorkshire and Humber. We received over 5,000 calls relating to toothache in children under 10. 64% of those calls for the most deprived group. That compares to only 4% in the least deprived. Now you can see that, to me, that says a huge amount about the accessibility of dental services and who can't access them. I'm sure lots of people have had problems getting dental appointments, but you can see it's very much focused in that most deprived group. And that just shows for this quite vulnerable group, these children under the age of 10, how much more need there is in that most deprived group. Next slide, please. It's also really important, so like Em was saying, it's understand that population. It's not just about deprivation. We'd like to know who they are by age and sex is a really important one. When we look at breathing difficulties, you often see this kind of pattern. We see a spike in the under 5s into that small younger age group, and then going into that much older age group. We see more ill health in that older age group, sort of chronic breathing problems will occur more in that older age group. It's really important to understand that for different conditions. So this is what it looks like for breathing difficulties. But if you click on ambulance calls for suspected STEMI, which is a kind of myocardial infarction and a kind of heart problem, you can see it's really different for males and females, and we've got far more in males than females. Just click again. So 2/3 of calls for STEMI were for males and only 30% for females. The average age for an ambulance attendance for STEMI in males is younger, so 63 compared to females, which is 69. So we can see different patterns by men and women, and that's really important to understand as well. What do we see that's different? Next slide, please. And when we look at our calls for mental health, instead of seeing that aging population that we do for lots of conditions that we go and see, we're actually seeing that this is something that's happened to our younger population. So 55% of all our calls for mental health were for patients under 40, and almost a quarter were for those aged under 25. Now, I've already told you I've worked in lots of bits of the system, and I kind of know lots of these things. I might expect to see some of these patterns by deprivation. I didn't expect to see this big spike in these young women, and I was really quite shocked about that. So I'm trying to find any route I can to make a fuss about this, because I didn't know that. I think that, so looking at ambulance data, I wouldn't have known that without this, looking at this data. So next slide, please. So we've already talked about inclusion groups. Thanks, Em. You've totally teed this up lovely for me. So we've talked about inclusion groups, but I think what's really important is for some of these groups, the ambulance service might be their main source of care. And they might be, we've got to remember that the ambulance service go out to see you in your home environment. It's very unusual compared to lots of other services, lots of other healthcare services. So they may be uniquely placed to know about the need for some of those inclusion groups. And many of these populations are missing from the data sets. It's really hard to find information on them. So I'm going to talk about the homeless population as a bit of an example of this. So next slide, please. So it's really good as well when people's slides actually agree. So the mean age of death for the homeless population was 44 years for men and 42 years for women, and that's about half the mean age of death for the general population. Just keep clicking. I don't know why I put all these like this. So from December 22, the ambulance service started to collect data on the accommodation status of patients, so including homeless without accommodation and homeless in a night shelter. So those two things are slightly different. So the homeless population might not present to healthcare in the same way as other people, and the ambulance service is often the first port of call for this population. And we've actually done a really detailed piece of work within Yorkshire Ambulance Service, going out and actually speaking to the homeless population. And there is lots of reticence about going to A&E because they feel really uncomfortable. They don't want to be there. They feel uncomfortable for how they look or how they might smell. They feel really difficult about it. They have lots of complex needs. So the ambulance service probably see this population more than lots of other groups, lots of other services. So what's really important is, so we saw nearly 2,500 patients who are experiencing homelessness. But not only do we know lots about those patients, we know what was wrong with them, their age and sex, we know who those people are, we also know where did we pick them up. And actually that can be really, really difficult for the homeless population. How do we know where to target an intervention? If we wanted to do something to that population, if we wanted to try and make things better, how would we know how to do that? Now, the ambulance service collects data, obviously, on where did we go. So lots of the data sets only tell you about where does that person live, not where did we actually see that patient. So this enables us to do a project. This is Hull. Sorry, I didn't have a West Yorkshire based slide for this because we actually did this project in Hull. But it meant we could target this population, go out and speak to this population, understand what their real needs were and what was their experience of the health service, what was experience of the ambulance service. Is it us that they use, or is it other parts of the system? And I think this is really important data that we should be sharing with the rest of the system. Next slide, please. So limitations. We've talked about ethnicity a lot, and this is us airing our dirty laundry. Our collection of ethnicity data in the ambulance service is really poor. I mean, sometimes if somebody's having a heart attack, that's a really inappropriate time to ask them what their ethnicity is. So we can understand sometimes why that's so poor. But it means it's really difficult for us to look at whether there are different patterns for different ethnic groups, whether there's different needs. And I think that's really important. And Ruth and I are involved in some national conversations about how we might improve this. I think that's the last slide. So Ruth, I think you're going to just do a little bit of a summary.
Yes. So in summary, ambulance data, I think, reveals some significant health inequalities in Yorkshire, especially amongst the most deprived populations. And I'm hoping that you can see that it does suggest significant value in sort of measuring those health inequalities and identifying some of that unmet need that Verity talked about. But I suppose the key thing for us to say is this is just a starting point. And we have been very told you my words don't come out. We have been very limited by resources, staffing and time. So I think from our perspective, the lessons learned are don't take on too much, because the more that we've talked about this, the more that everybody said, oh, this is really interesting. Could you do this? And could you do that? So don't take on too much, but just do a few things well. and for us, I suppose this was really about kind of proving that concept, and now as an organisation we need to think about how we can start to embed this sort of analysis moving forwards.
Absolutely amazing. Thank you so much. I think that really captures just brilliantly the work that you guys have done and how you've been able to reach the different populations that were completely sort of almost invisible before. And for somebody who also loves data but is also not the best at data, that's made it really sort of engaging for me and helped me understand. So I sort of, you know, if I understand it, there's no excuse for anybody else, because it is incredibly important. And exactly as you said, Verity, you know, the right data at the right time can actually move mountains. So knowing, again, I'm going to hammer this home so much, but just knowing that it exists, you don't need to be an expert in this data. Knowing that it exists, that we have colleagues across the board who can help you with this. If you're not sure where to start, speak with us. So, you know, speak with the West Yorkshire Innovation Hub. We can make introductions and you know, get you talking to the people that you need to speak with your manager, speak with your colleagues. It's just having that conversation, because somebody will know something and somebody, and that will lead on to the rest of the conversation. So really hope that's been useful for everybody on the call today. It is just a snippet, and there's so much that we could talk about, but an hour doesn't afford us that much time. It is worth saying we chose an hour on purpose at lunchtime on purpose to try and get as many people here as possible. But we do appreciate that it isn't long, and it doesn't allow us to go into loads of depth about things. So it's meant to be the catalyst for you to start that conversation, you know, with us, with each other, about what we can do to take forward. So that's everything today. We do have our general unusual sort of QR code if you want to take a scan of that. Molly, if you're able to put, she's already on it. If you want to put the link in the chat, so if you're not able to use the QR code. I would use this opportunity to sort of say next week is our last session. So if you've got any questions that you want to ask, please use that form to do so, because then we'll cover them in that last session. And I'll really use those to we can put some time aside next week to look at some of the comments and questions, anything that you want to cover that we haven't yet, you know, anything at all. Please use that forum to get in contact with us, and we can try our best to make sure that we cover it next week. So with 2 minutes to spare, and it's the first time that we've ever run to time properly, so thank you all so much for being so well behaved and sticking to the times. Thank you very much, and thank you so much to everybody for joining us. As always, it wouldn't be what it is without you guys and the amazing speakers, so thank you everybody. Have a wonderful afternoon, and we'll see you for the last session next week. Take care. Bye everybody.